good evening, everyone. Warm welcome on behalf of Department of Heart and Lung Transplant, Yashoda Hospitals, Hyderabad. So it's my pleasure to announce the start of our online web series, wherein we are focusing to reach out to you on topics pertaining to both medical and surgical aspects of lung transplantations and including management of end-stage lung diseases and ECMOs. And we'll be coming up with eminent national and international faculties who have excelled in this field. So looking forward for all your support, and please stay tuned for the updates. And today will be our first episode of this transplant webinar series, where we will have a small introduction and introduction to the program, and also how to regarding the best time of referral to a transplant program. For this, and I'm happy to have my mentor, Dr. Nagarjuna sir, as a moderator for this session. Nagarjuna sir doesn't require any introduction as such. He's not only just my mentor, also an inspiration to many young budding interventional pulmonologists in the country. So he's the leading interventional pulmonologist at Yashoda Hospitals, Hitec City, and he'll be moderating today's session. And we have two speakers whom sir will introduce as we go on. Thank you, sir, for accepting our request to be a moderator today. I request you to take on the proceedings and start the program.
Thank you so much, Chetan, and welcome everyone. I think it's wonderful to be moderating the first of its kind of web series focusing on lung transplantation. Hope I'm audible to everybody.
Yes, you are.
You can hear me? Yes.
Yes.
Okay, so I think this is a topic which is the need of the hour, a topic which needs to be taught, a topic which needs to be learned. And if we see in the last 10 years, the way pulmonology has been exploding in India, in the last few years, there has been an increasing interest, especially in lung transplantation. I think 10 years down behind, before, I think lung transplant was something which was only thought it was done abroad, not in our country, but things have changed, times have changed. So we are seeing lung transplant as a viable option for many of our patients who otherwise couldn't make through. There is increased awareness of lung transplant, not only amongst the doctors, but also amongst the public. So in fact, nowadays, many people come asking for lung transplant. So I think it is very important for a pulmonologist to know when we have to refer a patient to the transplant team. So we have dedicated transplant teams across the country. I think they should be a part of our learning now, because if we do not offer transplant to a person at the correct time, we will be depriving him of an opportunity to survive. So the acceptance to transplant has increased, and the access to transplant teams also has increased. I think so in the coming years, we would be seeing more and more patients benefiting from this lung transplantation. The same thing which happened to kidney, then to the liver, is sure going to happen for the lung also. And with this brief introduction, let us start off with the two talks for today. I think this is a very, very, very important thing, because before we go into the intricacies of lung transplant, we should know when a person should be referred. So to educate us on this very important topic, we have two very young and dynamic pulmonologists with an exclusive interest in lung transplantation. I think this is very important. So the first talk is on lung transplant golden window and indications. This would be delivered by Dr. Vimi Varghese. The second is on challenges of late referral and outcomes. This would be by Dr. Kapil. So now let me introduce Dr. Vimi Varghese. So Dr. Vimi Varghese, after his pulmonology training in India, he has gone all the way to Belgium for his fellowship in lung transplantation. And after getting expertise, he's come back to serve the patients of our country. And now he's currently associated with Yashoda Hospitals as a transplant pulmonologist. And so is Chetan, who has introduced me. So we're lucky to have both of you. So I would request Dr. Vimi to take over and deliver his talk on the golden window and indications. Over to you, Dr. Vimi.
Thank you, sir. I'm just trying to share my screen.
So before Dr. Vimi starts, I would request all the audience if they have any questions, please put them in the chat box so that we can have them answered by the experts.
Is my screen
Yes.
visible?
Yes.
Sure. Good evening, everyone. My name is Dr. Vimi Varghese, working as a transplant pulmonologist in Yashoda Hospitals, Hyderabad. I think it is a talk that which we want everybody to be understand the basic concept before we get into the details of lung transplant. So my topic is the lung transplant, the golden window and indication. So I'll be speaking about what is a golden window, what are the aims that we are trying to achieve by transplant, and what is we often hear about what patient is being referred, patient is being listed. So what are the two concepts of referral and listing, and what are the individual indications in brief for individual conditions for transplant, and what determines a success in lung transplant. So Yashoda Hospital, it's a group of 4 hospitals based in Hyderabad, and we welcome everyone from Hyderabad for this interesting session. So this is our heart lung transplant team from Yashoda Hospitals. We have a dedicated surgeons, intensivist, and anesthetist, and perfusionist, and we form a young group who is performing the heart lung transplant in our hospital. So we often hear about when I should refer, or am I referring it too late? So in a lung transplant, there are 2 concepts that arise. First is the primary physician or a pulmonologist who is referring a patient to a transplant center, which is called a referral. And after being referred to a transplant center, this patient is being evaluated in the transplant center in the form of pre-transplant evaluation. And when the transplant center feels it is the right time, he's being actively listed in a state board or state transplant registry. It's called as Jivandan in Telangana. And the same, there are different registries across different states. And he's being waited for his donor at his right time and the right organ, and the transplantation happens. So there is always 3 processes. There is always a referral, then there is a listing, then the waiting time, and there is a transplant happens. And always when a patient is being planned for transplant, the usual question that everybody has in mind is, am I referring at the right time, or am I referring it too early or too late? So before I coming to the aims of transplant, usually we refer a patient for a transplant when their 2-year predicted survival is less than 50%. There are different modes of understanding the survival rate, because in a chronic obstructive pulmonary disease, there is something called a board index, and in a transplant listing, there is something called lung allocation score, etc. So this is the basic concept that we should understand when a patient is being referred for transplant. Now coming to why the right window is very important. So as you know that transplant is a long journey. So each member of the family, the patient, the doctors, all has a very important role in terms of motivating the patient as well as a family relative, as there is an important role of physiotherapy. There is an important role of after the transplant, patient should be on lifelong medication. So many people, when they come at the late time and when patient is very sick, there usually do not have so much time where each family member and the patient relatives is being explained in detail about these aspects. So in our center, we have a academic room where after the consultation, we specifically discuss with the family about what is the journey we are talking about. So this journey is not only the journey in terms of the benefits of transplant. We also tell us about how they should be dealing in short after transplant in terms of medication, in terms of how their daily lifestyle changes, etc. Now, when we refer a patient to a transplant center, sometimes the diagnosis there will be an alternative diagnosis where there is a treatment option. In short, there are different connective tissue ILD where there is an evolving role for rituximab or monoclonal antibodies, etc. Some patients will be too risky for transplant, where we can give some options of lung volume reduction and vapor ablation, etc. So discussing the treatment option at that time is very important. And the third thing is that different indication for transplant has a different outcome. For example, a chronic obstructive pulmonary disease has a good prognosis as compared to a primary pulmonary hypertension. So these are all that we have to educate the family and the relative, and each transplant team should be knowing about this aspect. And another important problem that arises is the infections that happens before the transplant. So we have many patients with the bilateral bronchiectasis who has a recurrent Pseudomonas infection. And while they wait for transplant, they get another bloodstream infection, which we should aggressively treat and make sure they are at least infection-free before the transplant. Next important problem that we come across is either it's a malnutrition or it's an overweight. So both has to be taught to the patient. Like we give a protein supplements, and the overweight category, we try to tell them to practice physiotherapy on oxygen, which everybody should be educated about. So these are the few things that we take a great interest in the pre-transplant evaluation and optimization for each patient. And most of the time what happens is many patients who had a recurrent blood transfusion or who had a pregnancy earlier, they will be sensitized, or in short, when there is an antigen antibody reaction happening, it is called an HLA sensitization. Now, when there is a sensitization, when we do a cross match from the donor blood, there happens to be a sensitization. Sometimes we might have to reject the transplant because if you take the cross match that is positive, there happens to be an antigen antibody reaction, and lots of issues happen post transplant. So most of the patients that who are sensitized, when they get admitted for transplant and finally we reject, they do not understand this concept of what is HLA that the doctors is talking about. And next comes the important thing of physiotherapy. A good motivated patient who is undergoing a physiotherapy, who's maintaining the BMI also adequately is the right candidate that is required in the transplant. Now, this is a small report that I wanted to share that we came across in a patient a few weeks back. So this patient is a case of 41-year-old female who presented with a scleroderma ILD in respiratory failure. Now we can see that this is an esophageal manometry that we perform for many connective tissue disease patients, especially for scleroderma. And while performing the manometry, there is almost 90% failed peristalsis. Now, this is one of the things that we try to focus on, because unless and until we optimize this, either medically or surgically, after the transplant, patient gets into a lot of reflex symptoms, and finally patient will have a lot of difficulty taking this drugs also. So there are many subtle things or very small things that we try to look into so that our transplant journey is a success. Now, coming to what are the aims of transplantation. So in short, there are mainly three aims. One is to save life, and second is to prolong the survival, and third is to improve the quality of life. Now, always there is a normal term that we tell all the patient that you will have a normal life after lung transplant. But however, our expectation as a doctor and from the patient perspective will be very different. Most of the patient will be thinking that they'll be able to perform daily activities, be there for their family members, do sports and other hobbies, to travel, marry, have children, and to live a long and a prosperous life. However, from a doctor's perspective, it is to save life, it is to achieve or maintain a good functional capacity and to have no side effects and to avoid the comorbidities and to perform the daily activities. Most of the time, always there is a mismatch and there requires a lot of counseling. So in the pre-transplant period, a doctor and the transplant team will have to counsel the patients a lot to make sure that both the patients and the doctor's expectations are not mismatched or is at the same level. Now, world across, there is a change in the data for an adult lung transplant and a pediatric lung transplant. In an adult, in the adult lung transplant, most common indications are a COPD followed by interstitial lung disease, cystic fibrosis, and lastly, the pulmonary hypertension. However, in our center, around 55 to 60% of the patients that we do transplant is interstitial lung disease, followed by bronchiectasis, and then comes the chronic obstructive pulmonary disease and the pulmonary hypertension. Now, there are many contraindications for lung transplant. What I wanted to specifically importantly telling is, first thing is that when a patient is not willing for or accepting for transplant. So most of the time what happens is most of the patients get admitted with an exacerbation, and many of the patients are and the relative will be not willing to take up this huge risk or the huge surgical intervention that we are trying to perform. So they'll be telling, I'm not willing for this transplant. So it's all the motivation that we have to give to understand what are the benefits that we are trying to achieve. And who has a malignancy in the recent past, we tried not to take this case, except there are some few indications that will be coming through. And who has a GFR of less than 40, unless and until that patient is being planned for a combined lung and a kidney transplant. An acute liver failure, an active infection in forms of tuberculosis, HIV infection with a detectable viral load, and an active substance abuse, and other uncontrolled medical condition that is expected to limit the survival. Now, if you ask me what is the test that which is very important in a pre-transplant and a post-transplant, it is the spirometry. Because spirometry decides what stage a patient is on and whether we should actively refer this patient to a transplant center or not. Now, this is spirometry doesn't have that much relevance in a pulmonary hypertension. However, all other condition has an important importance in the patient's journey for a transplant. And always before denying or referring, or it is advisable that you speak directly to a transplant pulmonologist in that center to make sure which condition he should be referred, or we should think anything else as an other option. Now, generally for an ILD, an FVC of less than 80% is an indication for referral for transplant. And what I wanted to tell the people is that even though there are many numerical values that we should be remembering, in short, to understand is when there is a progressive decline in the lung function, and if the patient is having recurrent exacerbation with the pulmonary hypertension, it is a indication for referral for a transplant, a lung transplant center. Coming to specifically a DLCO of less than 40% is an indication for a interstitial lung disease. And coming to a cystic fibrosis, the cutoff is FE1 of 30%. Same wise, a patient with an FE1 of less than 20%, the indication for listing for a transplant. Now we will go to an individual condition, but instead of boring everyone, what if you ask me what is the important parameter that everybody should be knowing in a chronic obstructive pulmonary disease? It's mainly 2-3 aspects. One is the BORD index. Now BORD index has 4 parameters. One is the body mass index, FE1, MMRC score, and then 6-minute walk distance. So based on the BORD score, we refer or we list the patients for transplant. Now, in a chronic obstructive pulmonary disease, the FE1 cutoff for referral is 20 to 25. However, if it is less than 20%, it's a condition for listing for transplant. However, along with this, if there is a presence of recurrent exacerbation, pulmonary hypertension, chronic hypercapnia, is an indication for listing for a lung transplant. Now, coming to interstitial lung disease, in short, what I want to tell is a referral. Once an interstitial lung disease is diagnosed, it is advisable that when we discuss a treatment option, we should be telling that a lung transplant is also a indication where if there is a progressive decline in lung function with a FEC of less than 80% or a DLC of less than 40% is an indication for a lung transplant. However, most of the time that we come across is when a patient comes for a serial follow-up, they'll have progressive decline in FEC, DLCO, and along with that recurrent exacerbation or recurrent hospital admission. So a patient with the oxygen desaturation, pulmonary hypertension, progressive decline in lung function is an indication for referral. And if it is happening in the last 6 months with the pulmonary hypertension and desaturation is an indication for listing. So in short, what we should understand is a patient with a progressive decline in lung function, patient with a respiratory failure, or those who are requiring an exertional desaturation requiring oxygen therapy, and a pulmonary hypertension is an indication for referral to a transplant center, and it will be decided to whether to actively list or not after coming to a transplant center after discussing with the team. Now, in cystic fibrosis, the magic number what everybody should remember is 30. And however, if the FE1 is less than 40 with the 6-minute walk distance of less than 400, raised PCO2 and pulmonary hypertension is an indication for referral. However, those whose FE1 is less than 25%, rapid decline, pulmonary hypertension, chronic respiratory failure, and an exacerbation with requiring mechanical ventilation is an indication for listing for lung transplant. Now, pulmonary hypertension, if you ask me what is the important aspect that we should think, it is a REVEAL score and the need for injection, need for IV or subcutaneous prostacyclin, and an RV dysfunction. And if there is an organ dysfunction in terms of liver, kidney, or a hemoptysis, it is an important indication for a listing for transplant. So a pulmonary hypertension patient who has a high REVEAL score, who has an organ dysfunction in terms of hemoptysis or kidney or liver dysfunction, and those who are having a significant hypoxemia, who are on multiple vasodilator and still having persistent symptoms, is an indication for referral to a transplant center and then decide on listing. There is an evolving evidence that is coming up in thoracic malignancy, especially the lung-limited adenocarcinoma, minimally invasive adenocarcinoma, and lipidic predominant adenocarcinoma. Now, this is for patients where surgical resection is not feasible because of multifocal disease, and multifocal disease has resulted in significant lung restriction, and the multiple oncological therapies have failed, and lung transplant is expected to be a curative. This is an evolving field that requires a lot of multidisciplinary discussion. So in short, lung transplant is a life-saving treatment for most patients, and it is advisable to discuss the risk factors and contraindication with the transplant center before declining a patient for transplant. And careful selection of candidates, it's a moral duty given the low donor numbers. It is a crucial for good long-term outcome, and the timely referral is preferred. And as we know, it is a teamwork of the doctors, patient, and the relative that determines the success. Thank you everyone for a patient hearing.
Yeah, thank you so much, Dr. Vimi, for the excellent lecture on the indications, the difference between referral and listing, correct?
Yes.
I think that is something which we should all understand, that referral doesn't always mean listing for lung transplantation. So, but before we go on to take the questions or discuss further, I would introduce the next speaker for today, which is Dr. Kapil Iyer. Dr. Kapil Iyer would be talking on challenges of late referral. I think this is very common in our country, because most of the time, by the time people are suggested transplant or by the time they accept transplant, it would have been too late. So Dr. Kapil Iyer, also like Dr. Vimi Varghese, has an interest in lung transplant. So he has done his fellowship in lung transplant from UK, and currently he is heading the Department of Lung Transplantation at CIMS Hospital, Ahmedabad. Over to you, Dr. Kapil.
Thank you so much, Dr. Nagarjuna sir, for those warm word of welcome. And at the outset, let me just thank Dr. Yashoda Hospital, the entire team, Dr. Pawan sir, Dr. Sunil sir, Vimi, Chetan, as well as Dr. Nagarjuna sir, because this is a topic which is very close to my heart. And all of us know that the information about lung transplantation is really required. And the fact that Yashoda is going to do regular CMEs and online webinars about this is something which all of us are really happy and excited. And thank you so much for letting me be a part of this. Now I'm very happy to go second because a lot of my discussion has already been touched upon by Dr. Vimi Varghese. So I'm going to be talking about challenges and impact of late referrals for lung transplantation. It is a burning topic and it is a very practical topic, because this is what exactly happens whenever we sit in our lung transplant outpatient clinics. So I'll be just briefly having like an introduction. What exactly are the logistics of the lung transplant process? And I want to discuss about challenges as well as impact separately. So as far as introduction is concerned, lung transplantation has definitely emerged as a definitive treatment option for all end-stage lung diseases. Obviously, Vimi has spoken about individual diseases, but as a group, it's all including chronic obstructive pulmonary diseases, interstitial lung diseases, which obviously includes mainly idiopathic pulmonary fibrosis, cystic fibrosis, which is not really a disease which we see very commonly in India. But if you probably go to Scandinavian countries, UK, as well as Canada, cystic fibrosis is a very common indication. And I must say that one of the reasons why they have got a very high overall success rate in as far as survival is concerned is because a lot of their subsets include cystic fibrosis. In our country, the non-cystic fibrosis bronchiectasis will be more common, as well as pulmonary hypertension. Now, in India, several centers have performed lung transplantation, and many more are obviously in the process of establishing a lung transplant program. Now, when I talk about logistics, I want to talk about the practical points of what exactly happens. Okay, so I've just got these broad headings which I briefly want to discuss. So first is obviously the referral. Now, Dr. Vimi has spoken exceptionally about the golden window. Okay, so we are talking about referrals either from pulmonologists or internal medicine guy or GPs, or it might be possible that the patient will come on their own to the lung transplant clinic. Now, this is where we basically have a very important role of the transplant pulmonologist, because these guys will be at the center. They will be the first people to initiate a conversation with the patients, and they will assume the lead role when it comes to decision making. Obviously, everyone recognizes the two people which I'm showing over here, Dr. Vimi and Dr. Chetan. who are obviously the transplant pulmonologist in Yashoda. Now, there is an in-depth counseling, and this happens in the first interaction with the patient. Trust me when I say this goes on for a minimum of 45 minutes, because this is where actually you're supposed to go through the entire history. Sometimes patients land up with 3 to 4 files of their history and CTs, and you go through all the serial pulmonary function tests, 6-minute walk distance. And actually we all fail to realize that how emotionally draining a first-hand counseling of a lung transplantation can be for the patient and the relatives. So this is a very sensitive portion, and it has to be done in depth and in a very sensitive, in a very confidential manner. Now, third is something known as a pre-transplant assessment. Now, like Vimi mentioned, we may get a lot of referrals, but this does not mean that all the referrals that we get are ultimately going to be transplanted. Oh, I'm so sorry. Can you see my screen now?
Yes.
Yeah, so we might get a lot of referrals, but it is not necessary that every patient is fit for a lung transplant, which is why we need to evaluate these patients. And what I've shown on the screen is just an example of what all investigations are supposed to be done for these patients. It's just grouped and called as a pre-transplant assessment. Now, this will include your various investigations, starting from a chest X-ray to a CT to a CT abdomen. We've got right heart catheterizations. You need a detailed coronary angiographies. You need, OGD scopies. You need esophageal manometries. You need colonoscopies in elderly patients. You need obviously your, pulmonary function tests. You need serology, and of course, you need a lot of consultations which needs to be done. Infectious disease needs to see gastroenterologist, ENT, the cardiologist, the physiotherapist, the dietitians. So this actually is a very detailed assessment. And ideally, we prefer hospitalizing the patient for at least 4 to 5 days, so that it is just much more convenient for the patient, and it is much more convenient even for the center, so that it's like a one-stop admission. 4 to 5 days, we get everything that we want and then discharge the patient. So this is again a representation of all the people that actually come and see the patient. So right from your nurses to your physicians to your immunologists to your transplant coordinators to your surgeons, your anesthesiologists, your pharmacists, and your social workers, etc., etc. This obviously will vary from center to center based on the experience, based on the availability. And after this, we've obviously got this multidisciplinary team discussion which happens. Now, this discussion is basically, it's just a culmination of all different specialists, especially the transplant pulmonologist, the general pulmonologist, the cardiothoracic surgeons, the cardiothoracic anesthesiologist, and the intensivist. These are the 5 main people which are definitely required. And based on different centers, you can also involve the radiologists, the physiotherapists, the dietitians, the transplant coordinators, the infectious disease specialists. Everybody can be a part of this MDT discussion. This is where the main difference between a referral and a listing takes place. So a patient might be referred to your center, and after this MDT discussion, if the entire team deems fit, that is when the patient is so-called listed onto a lung transplant wait list. And this is obviously a representation of NOTO. Remember, Dr. Vimi said that as far as Telangana is concerned, you've got the Jeevan Daya. So you've got different state level organizations for different states. For example, Gujarat has got something known as the Gujarat SOTO, which is the state organ transplant network. But eventually, all these patients are listed and registered onto the NOTO, which is the National Organ and Tissue Transplant Organization for India. So the reason that I have actually explained this process is because this is a very in-depth process, and it is very, very emotionally, financially, and mentally draining for the patient as well as the family members. So all of this has to be explained in detail and carried out in a very professional, diligent, and a very confidential manner. And all the results of the MDT also have to be conveyed to the patient and relatives accordingly. Now, I just want to first take on the challenges of late referrals and followed by what exactly is the impact of these late referrals. Now, I'm going to be talking about all practical points about what we have seen and what really happens. Now, I've got these 8 different points which we feel are the challenges for late referrals. Now, obviously, this by late referral, there was a diagram which Dr. Vimi showed, the golden period. I'm obviously talking about the latter half of the golden period or something which has already crossed the golden period. So first is, before I actually describe, let's just look at the ISHLT referral criteria for ILD. I do not even want you to go down just the first 2 points. Imagine this is official ISHLT data, which shows that when a pulmonologist even diagnoses UIP pattern, actually the guidelines mention that there should be a lung transplant referral. And even read the second point. Any form of pulmonary fibrosis with an FVC of less than 80% predicted or a DLC of less than 40%, I would rather pay attention to the 80% number. Now, by this criteria, actually, all of us know that majority of the patients who even land up to a pulmonologist in our country will actually satisfy an FVC of less than 80%. So obviously, by this accord, Vimi and I should have very busy OPDs. But obviously, there is a distinction in just copying pasting ISHLT criteria and whether it is actually applicable or can we implicate this in Indian circumstance. This is something which only time is going to mention. Now, what are the challenges? The first is obviously progressive disease. Look at the patient on the left. This is a patient who is mobile, walking, suffering from a chronic lung disease, which is evidenced by the fact that she is on an oxygen concentrator, which is a portable thing. Ideally, these are the subset of patients who should be referred at least to a transplant center so we can have an in-depth analysis. We get more time to spend with the patient, talk to the patient, and they are mentally more ready, and this will obviously lead to a better outcome. But instead, what exactly do we see is the figure on the right. We actually get referrals in which this is what happens to a patient. They are completely bedbound. They are on all sorts of ventilators. They have been bedbound. They are not being weaned off. And this is when there is even a discussion with the family members that, okay, let us at least consider lung transplant. But, unfortunately, this is a patient which will have a very bad prognosis as far as survival post lung transplant is concerned. The second point is obviously an increased rehab burden. Now you can see the patient on the left, again on oxygen, able to exercise. See, all of us, we need to pay attention to this, that lung transplant, when we are just implanting lungs is nothing but a pair of balloons. The fact is that we need to inflate and deflate these balloons depends on the thoracic muscles of the patient, depends on the muscle power that the patient can generate. Obviously, if you leave the patient very late in the course of disease, that is when this patient is bedbound, cannot mobilize, does not have any of the thoracic muscle strength, and they have got obviously increased rehab burden before as well as after the transplant. So burden of the process, of course, this is one of the reasons why I basically gave an introduction of a very practical thing of what really happens in a transplant center by explaining everyone very shortly about the listing process. I already mentioned it's a very in-depth analysis, takes time, patients are really confused. And in our country, we've got a lot of patients who've got the tendency of doctor shopping. So, they will first listen to Vimi, they will go to Chetan, they will come to me, they will go to Apar. This is the practical things, what exactly happens in our country. If they are already too late and suddenly you talk to them about pre-transplant assessment and you have a 1 hour in-depth talk to them, chances are that they are just going to say no, and it is too much for them to take mentally as well as emotionally. BMI, obviously, again, Vimni touched on this. Extremes of BMI is extremely difficult to combat. We have got very clear-cut guidelines which says that the patient has to have an appropriate BMI so that the outcomes are much better. If a patient is on a wheelchair, completely can't mobilize at all, and if the patient has got a BMI of, let's say, 38, it's extremely difficult for us to get the BMI down below 35 so that at least we can list and give this patient a chance of a better outcome. And the same also goes for patients who are malnourished. Okay, if you've got a BMI of less than 17.5, it is very difficult. It's something which we come across in patients of cystic fibrosis, patients of congenital cardiac defects like Eisenmenger's with pulmonary hypertension. These are patients who just do not thrive. So we need time with these patients, to get the BMI up to an appropriate level so that we can deliver good outcomes. And of course, look, all of us are Indians. Obviously, we are number one when it comes to the world population. We are a very heterogeneous population. We have to understand that different states in India have got a different organ donation rates. If I can name 4 states which are really doing good, Telangana tops the list, followed very closely by Tamil Nadu, Karnataka, and Gujarat. The others, unfortunately, comparatively, are lacking behind. And the second that I want to mention is about the administrative help. So we have got different governments, different state governments who financially help the patient. I can give the example of Gujarat government. So over here, patients will get 10 lakh rupees, which will be given by the government for a double lung transplant or even for a single lung transplant. I am not very sure what the financial help is in different states. I know that Maharashtra is not 10 lakhs, it is slightly lesser, but Telangana is something which probably Dr. Chetan and Dr. Vimi will be in a better position than me to explain. So scarcity of centers, Dr. Nagarjuna sir mentioned in his introduction, yes, we are in the upswing when it comes to transplant centers, but for a country of 1.4 billion and the respiratory burden that we see, it is still less. If I can give you an example, suppose a patient from Kashmir, comes to Yashoda Hospital and is listed in Yashoda Hospital, the entire family has to move to, Hyderabad. They have to live over there. There is a financial burden. It's a new state. It's not easy for the patient. So we definitely need more centers in our country. And of course, this is a topic which I don't know why, but it is never discussed. But this is one of the most practical problems which we face, which is a financial burden. I want to remind everyone that, see, lung transplantation by itself is an expensive affair. This obviously is a relative statement, but if a patient comes late to us, the financial burden further increases, because remember, this is the patient who is going to spend more time in the ICU even post transplant. So the cost will definitely escalate. So these are, as far as the next point which I would just like to mention is what are the impact of the late referral. So how is this going to exactly impact on the transplant program? So these are the brief topics which I would like to cover. So first is obviously the unwillingness and the confusion. Like I already mentioned, evaluating a patient itself, and suddenly imagine a patient of ILD who's on Perfenadone, who's already doctor shopped, who's gone to every specialist. Somehow things are not working. It's already too late, bed bound on not even able to get on a wheelchair. Suddenly this patient comes to a transplant pulmonologist and there is a 1 hour discussion. He is already so breathless, he's so anxious, he's so unwell that they just become more confused, and there is a lot of unwillingness. We obviously see certain patients who are like, whatever it is, do everything which is possible, but that is too far and less in between. Obviously, ECMO is a huge topic, and I'm sure that Dr. Vimi and Dr. Chetan will definitely dedicate a different session to ECMO, pre and peri operatively. But as we all know, ECMO can be used as a bridge to transplant, but it is a very difficult conversation to have with these patients. because they are, as it is, they are too unwell. And remember, ECMO by itself also gets its own complications. You will have, thrombocytopenias, you will have bleeding, you might have thrombosis, you might have clots migrating, and the ECMO by itself is also an expensive affair. So these are all something which we have to understand. Poor survival, which according to me obviously is the most important point of the impact of a late referral. Now the first statement which I have given is, obviously these are the official ISHLT statement, that the 1 and 5 year survival for adult lung transplant recipients since 2010 is around 85 and 59% respectively. So remember, majority of the centers which are there in the ISHLT registry are high burden centers. They are high volume centers with a great amount of experience, excellent protocols in place, and a very thorough, furbished sort of manner in which the transplant occurs. In our country, we definitely need to scale up and ramp up the transplant services, which I'm sure will happen in the next 5 to 10 years. Even though all these high volume centers, it still has got a 5 year survival of 59% worldwide, which is not a great survival if you probably look at kidneys and livers, for example. But of course, the later a patient is referred, the more moribund the patient is, more the comorbidities, higher or lower the BMI, 110%, this will have poorer outcomes. And needless to say, the impact will be an increased financial burden. Remember, I mentioned the point that the patients will be more time in the ICU. All of us have worked in the ICU. We know that the more time you are in the ICU, more chances for you to get, some sort of an infection. Your line related infection, catheters related infection. You are a sitting duck for a lower respiratory tract infection. So there are so many things which can go wrong. Your cytomegalovirus can start getting reactivated. So, the more time you spend in an ICU, the more chances that you have got these infections, which will obviously increase the stay, increase the cost, increase the anxiety, increase the frustration of these patients. Very important point, but a very under discussed point. Late referrals is equal to difficult programs, is equal to increased cost burden on the relatives, is equal to increased frustration, not only on the relatives, not only on the patient, but also the medical staff. Remember, if the outcomes are poor, this will directly be proportional to a decreased medical motivation and burnout of the entire transplant team. It is an aspect which unfortunately is not discussed a lot. So summary, India is still in a nascent stage as far as lung transplant is concerned. Early referrals are definitely paramount and extremely important for a successful lung transplant program. Late referrals has its own challenges, its own impact. One of the, let me just mention the most important ones. Of course, decreased survival, increased financial burden, and medical burnout. Thank you all so much for your patient listening.
Thank you so much, Dr. Kapil, for excellent slides as well as the excellent talk. And I think now we are all very clear that if you refer late, it is more difficult both for the team as well as for the patient. So I think with this, we will quickly move on to discuss a couple of things, some questions which we have and some practical things which we have to do. I request Dr. Vimi, Dr. Chetan, Dr. Kapil, all of them to share their opinions. So I think this session is mainly for Chetan. You want to say something?
I have a question.
Before you have a question, I will give you the chance. So I think this is all about indications and time of referral, correct? So I think Dr. Vimi has said in the beginning itself that the Indian data, ILDs top the list, not COPD, as opposed to the rest of the world where COPD tops the list. So any reasons for this? Is it only the age or anything else to do with it? I think Dr. Vimi, Dr. Chetan, anyone can take up.
So my question is somewhere related to the same.
Yes.
I also wanted to ask the same question.
Sir, basically this ISHLT data, there is always a disparity between the pediatric and the adult. So I think the most likely explanation is probably the chronic obstructive pulmonary disease, even though we see a large number. However, I think probably one of the reason is the late referral, and as compared to an interstitial lung disease where our Indian context, we see a lot in number, but as compared to a international center, it's very, there are a lot of disparities in this one, but I think this is probably one of the reason.
Yeah, I have one other question. See, of the ILDs, I think Dr. Kapil can take this question. Of the ILDs whom you get referral for transplant, how many of them are actually IPF, or how many are non-IPF young ILDs? Dr. Kapil.
So very good question, sir. So first of all, I would completely agree with what Vimi said. Interstitial lung disease is the number one disease as far as referrals for us is concerned. The quality of life of these patients is really bad, and these are the ones who are inclined to doctor shock. Now, you've asked a very interesting question between IPF and non-IPF ILD. In our country, if you see, there is a geographical distribution of ILD also, as we speak. All of us saw that even in the ILD India registry. You see states like Gujarat and Rajasthan, in which you have a lot of pigeon exposure. So here we are seeing a tremendous number of chronic hypersensitive pneumonitis. So if you ask me the question, which is the number one disease which you see in your patient, I will say it's chronic hypersensitive pneumonitis. Amongst the ILD, the second obviously is IPF, and sarcoid I will put it as number 3, because we do have a lot of patients coming in from southern Rajasthan who have got sarcoidosis. They come into our clinics. So that is the distribution which I see. This might be different in probably what Dr. Vimi or Dr. Chetan see in Hyderabad, but this is what I see in my clinic.
Yeah, quick comment from Chetan. So in the last couple of years, what sort of ILDs are the ones which are actually referred?
You mean, in our center?
Yes.
So in our center, off late, it is more of a trend of CKD ILDs that we're seeing, especially the younger generation. And I probably the last 1 month, we have seen at least double-digit numbers of people in 20 to 30 age group, more of scleroderma related and female predominant. And they're rapidly progressing despite all the immunologic therapies like rituximab, tocilizumab. And currently, as we talk, I have 3 active scleroderma young females waiting in the list who are high risk because of all extrapulmonary manifestations as well. And followed by post-tubercular bronchiectasis. So these are the 2 main conditions that we are currently following up in our clinic.
Yeah. So I think from what I understand, all over the country, it is more towards non-COPD, non-IPF, correct? So I think it is geographic dependent. Probably age has something to do with it. We tend to refer more of young people because everybody feels that they are the ones who benefit the most. Now, I have one question for Dr. Vimi. See, when you in your presentation, you discussed about the conventional indications for transplant, that is the COPD, ILD, PAH, so on and so forth. But there is a significant subset of people who come with refractory respiratory failure for whatever reason. Acute ILDs, acute severe viral pneumonias which are not resolving. So they're not the ones who were bad earlier, who never thought they would need transplant, but they ended up bad because of either an acute infection or an acute exacerbation. So the common question then asked is, Dr. Saab, why not transplant now? So I would request your insights on whether such people should be considered or not.
So I didn't press upon the topic because the common condition was what I pressed upon. So ISHLT has given an explanation for these kind of acute insult when we should consider transplant, especially in terms of 2 aspects. One is for the COVID-related acute respiratory distress syndrome, or infectious cause for acute respiratory distress syndrome that was there pre-COVID. So now, in case of a COVID-related ARDS, what the ISHLT document has told is that at least a patient with a respiratory failure, despite giving all the medical treatment, and after 4 weeks of complete acute medical care in terms of ventilatory or ECMO, and still having the persistent symptoms or the oxygenation status which is not improving after 4 weeks is an indication for transplant. However, in case of ARDS, which is an infectious cause, and that was there pre-COVID, even though the right weeks for referral for transplant is not very correctly written even in ISHLD, but the concept is after giving the good supportive care with the special care on oxygenation and treating the infection, and after that, if there is a persistent or a worsening oxygenation despite these treatment advances, so I think they are also thinking the weeks for transplant is at least more than 2 or 3 weeks despite this acute care intervention. So I think this at this moment of time, sir, from the ISHLD, this is the maximum aspect for the referral for transplant for this acute infective related ARDS, whether it's COVID or non-COVID, from the ISHLD that they are offering, sir.
Okay, so I think we'll ask Dr. Kapil also. So to keep it simple, if a pulmonologist has a respiratory failure, okay, should he involve the transplant team or not?
So, sir, obviously, assuming the fact that all causes and the optimization of management has been done,
Obviously,
and ECMO also has been discussed with the patient, I think it is worthwhile definitely to involve the transplant pulmonologist. This will need a very in-depth analysis. And, ideally what we do is we wait for a minimum of at least 3 weeks, like Vimi mentioned, 3 weeks is what we usually wait and we see. And this is a time when we can also discuss about ECMO with these patients as a bridge to transplant, and then take it from there.
Okay. Chetan, you want to say something?
Sir, I have a question predominantly for you. So I want to know your insights being a pre-transplant contact for an end-stage lung disease patient. So if you look at that, sir,
I was the moderator.
so, but we want your expert opinion.
Sure.
So basically, if you look at the ISHLD data worldwide, irrespective of regional differences, from 1990 to 2010, the condition that was predominantly, the patients who were undergoing transplant predominantly was COPD, which was somewhere around 37.3%. But if you look at data from 2010 to 2020, IPF took over. The overall number of transplants was 29% per IPF, and the COPD has come down. So I have two questions. Did we excel in managing COPDs medically so that they're progressing slow? And second thing, as we got trained, there is one thing that we learn about COPD. If a patient is not surgically fit for transplant, consider bronchoscopic or surgical lung volume reduction. And now that you have done the highest number of cases of bronchoscopic lung volume reduction, I want to know your opinion. Should we consider sending selective COPD patients for lung volume reduction before considering transplant?
I think the answer to the first question is very clear. I think we have become better in managing COPD. With the type of inhalers you have, I think the approach to COPD has improved. I think that is the reason why the outcomes of COPD have become better, and IPF has overshot COPD as the predominant indication for lung transplantation. Whether BTVA or any sort of BLVR are a replacement for lung transplantation, if you look at the GOLD guidelines, they do give, there is a mention about all of these things also. So I wouldn't say no, but at the same time, the number of people who would tick the criteria for bronchoscopic lung volume reduction surgery is very, very minuscule. So I think definitely there is a role. There is a role for BLVR, BTVA, and all of those things. In fact, if you ask me, people who are unwilling for transplant also will be willing for BTV or BLVR if we give it as an option. So definitely yes. So there is a role for BLVR and there is a role for transplant. I think both of them should be offered. In fact, for our patients of BTVA, we also tell them that transplant is an option for them. And if you're interested for transplant, yes, we can consider transplant for those people. And if BTVA fails, we also tell them it is not that BLVR or BTVA is successful for everybody. It will only improve their quality of life or symptoms for a couple of years. That's all. So these are all people who should be primed for transplantation. I think we have Dr. Balasubramoniam, who is our transplant surgeon, with his hand raised. Any questions? No, I don't think so. I think it just got raised by chance. Okay, now that we've discussed about the indications, the second thing, see, is about referral and listing, correct? So now let us not talk much about COPD, because COPD is not the prime disease which is being referred, if I understand correctly. Talk about ILD. I know if you're idealistic, we stick to what ISHLT has said. FVC of 80% for anybody, or DLC of less than 40% for anybody. But I think most of us do agree that it is practically not possible in our country, because you would require I think thousands of transplant pulmonologists to be counseling all these people. So what I feel is that every pulmonologist should have a tinge of transplant pulmonologist in him or her, so that he should be able to do the basic counseling himself, correct? So now to Dr. Vimi, I think, see, FVC of less than 80%, I think everybody will have. All ILD patients are diagnosed with FVC 80%. So practically, I know that it shouldn't be the criteria in India at least. Yes, and more so for non-IPF ILDs, especially for those ILDs where you have treatment options. I don't think that should be the criteria. So what, in your opinion, should be the time when a person should think of referring to a unit for pre-transplant evaluation? I'm not talking about when the idea of transplant has to be fed into the patient. I do agree that whenever you diagnose a person with IPF, you should explain to them that if you progress, transplant is an option. They should be primed about it. I'm not denying that fact. But when is it that you want to see a person in your transplanting?
So, as you said, sir, most of the patient that comes to a pulmonologist with an ILD, most of them will have an FVC of obviously less than 80%, or at least in the 50 to 80% range. And most of them, after being diagnosed and treated for an ILD, whichever be the type, obviously we want him to come for a follow-up. Let's say be at 3 months or every month or every alternate months. Then I think when we do a repeat spirometric assessment, when we see a progressive decline in the lung function, and let's say if he's coming for a subsequent follow-up, when he's having a progressive decline in lung function, and they are having a persistent desaturation on a walk test, or they're developing a new onset pulmonary hypertension, I think this is the point where we should really stress upon the patient that medically we have only few options left, but this is the right time that you should also go to a transplant center, get it evaluated, and speak to a transplant center that this is the patient which I'm referring, whether it be early or not, but it is advisable to keep the transplant center in the pipeline so that when it worsen at any point of time, we are actively involved the transplanting team, and also they are also very clear of the patient. Most of the time what happens is when they have a very ILD, when they're bedbound, who is having already severe pulmonary hypertension, it's very difficult to convince that patient at that time, because they will say that I'm already bedbound, I'm having a reasonably quite.
I will interrupt. I do agree. See, it's not that it is just a healthy debate. See, we don't want people coming in on bed. Definitely, yes.
Yes.
That is something which everyone should understand, that it should not be too late, because Dr. Kapil has clearly said, and I think it is very logical that you shouldn't be referring too late, but
Yes.
too early is also not correct. So if you say, I would agree with you that rather than a single number, a trend is more important. A
Yes.
decline in FAC or a decline in DLCO is what should decide whether the person should be referred or not. Now, again, 10% is what has been given in the ISHLD, correct?
Yes.
Suppose a person has an FPC of 70%, goes to 60%, able to do all his activities reasonably well, and has an 6 minute, when he walks, he has a mild exertional hypoxemia. So would you still want the person to be listed?
I think, sir, he should be actively referred, sir.
Referred,
because-
yes.
Yes, sir.
Correct.
But he should be referred, and what I want to stress is this is the time, most of the time what happens is they will be either obese or there will be malnourished, where we can really improve the outcome and the motivation of these patients. So
Okay.
whatever be the modifiable factors that we are able to achieve at that point of time, I think that is the point that we should stress at that moment, sir.
Yes, I think this is another important message for all of us, that despite optimal care, if the person continues to have deteriorating lung function, definitely he should be considered a candidate and should be referred. He may or may not be listed, but he should be referred. Am I correct?
Yes.
Now coming to another practical point, which I will ask Dr. Kapil. India is such a huge country, correct? So referral and listing obviously may not happen in the same state, in the same zone of the country. So how do we overcome this problem? See, if you're luckily in the same city or the same hospital where the transplant is happening, it is much easy for us to say, okay, you go, just talk to them, understand and come back. But for a pulmonologist who is there in a city where or a state where the lung transplant program is not active, so referring a patient who is unlikely to be listed is a very difficult thing, correct? So how is there any practical way to go about it?
Sir, it's a very practical question, to be very honest, because there are no guidelines and all, and there's no approach for this. But geographically, we're a very heterogeneous population, and unfortunately, if you look at the pulmonology community right now, the number of transplant pulmonologists is very less, even if you compare to the general pulmonologist involved. So, of course, there are very few centers. So, this is a very difficult question to answer. The one approach which I see is that the centers which are operating right now have got these concepts of mobile clinics, which you do in different states. You get in touch with the pulmonologist of that particular city, that particular state, and that is where they can sort of refer the patient to you when you're probably having like your monthly visit or something. Be in touch with the pulmonologist, speak to the patient, and if you really feel that the patient deserves, counsel the patient that at least you need to come to whichever is the most feasible, whichever is the most nearest center, because comfort factor for every family, every patient, every relative is going to be different. So you need to counsel patients accordingly. Similarly, I personally feel that even the transplant pulmonologists have to be in touch with each other. For example, if I get a patient from, let's say, Karnataka or something, rather than the patient coming over here, it's much more convenient for the patient to just go and see Dr. Chetan and Dr. Vimi. So, if we can plan things accordingly, that is how we can help the patient. And ultimately, I think it will take 5 to 8 years where we will see an upswing in the number of transplant centers, hopefully in different metros and different cities, which will be able to satisfy the overburden of end-stage lung diseases.
I think excellent, Dr. Kapil. So I think the thing to remember is though the centers performing transplant are lesser, you now have the teams who are coming closer to you. I think every state in India has a transplant pulmonologist from an actively performing transplant team visiting a city which is close to them. It's important that everybody is aware of those centers and people can make use of those centers, correct? Any role of communication or tele counseling for such people? What is your opinion?
There are two approaches in this. See, the answer is obviously yes. All of us have seen that in COVID, telecommunication was a big boon. But there are pros and cons of telecommunication. What I personally feel is, at least for transplant, the first point of contact should be in person. This is my personal opinion. Probably
I was actually waiting
differ.
for that answer only. That
Yes,
telecommunication will never give the same confidence as what a physical consultation would have. Yes, correct.
Yes.
So now before we close, I have another thing, which is what my patients ask whenever I bring up the prospect of transplant to anyone. Correct. This is the two questions. What is this success of transplant? Correct. So let us not talk about the international numbers. I think that one of you have shown 85% 1 year, 50% 5 years. Correct. So what is I think this is something which every patient is going to ask, both the referring doctor and the transplant team also. So it is important for us to understand the Indian statistics. Do we have the Indian statistics also about the long-term outcomes of lung transplant in our country as such?
So this is a very catch-22 question because, unfortunately, like you mentioned, we are armed with NHS data, we are armed with ISHLT data with regards to, the 5-year survival and all. If you specifically ask for Indian data, there is one paper which has been released by Global Hospital. I think all of us are aware this was, the number of transplants, I think approximately 132 transplants, which were done in the duration of 2017 to 2020. And they have specified the 1 year and the 3-year survival. The 1 year was roughly around, if I'm not mistaken, 85%. And the 3-year survival for these patients was roughly approximately 73%, which is comparable to Western data. Unfortunately, we till now, at least I personally have not come across an Indian paper which is mentioning about a 5 or a 10-year survival. I think a 10-year survival obviously is out of the question because transplantation hasn't been done for so long in our country. But I think it is awaited. Let's wait for reports of 5-year survivals, and I think that will boost our confidence, and that will be a major part of our counseling to the patients.
No, I think, see, the other thing is for us to counsel, for the general pulmonologist to counsel a person before referring, Dr. Vimi or Dr. Chetan, what would be the numbers which you would say? It would be unjust for us to say everything is true 100% survival. So what is the survival which you would project for an IPF or COPD? Is it the same for all the diseases, or is there any difference in survival based on the disease also?
So when a patient is like first time, when I have a meet with a patient for the first time, I quote the numbers from the world literature, and as Dr. Kapil rightly pointed, we have two papers actually. One is from Chennai and the other one is from Hyderabad, which CIMS also published. And both of the centers published only 3-year survival rate because most of the centers that are actively doing are more or less 3 years old. There are older institutions, but there's no data on 5 and 10 years. So I quote the same number, like I tell them 1-year survival rate as per world registry data is 80%. And 5-year survival rate is around 60%. But the actual risk associated in your case, I can figure it out only after a pre-transplant evaluation because that is a multidisciplinary approach that I do. And I get to know if there is any extrapulmonary risk involved in your case, and I can tell you exactly what is the risk and benefit. But overall, this is the number I quote when I meet them first.
I think it is good to know that we are going on par with the world standards as far as the survival curves are considered. I think we will look forward for more data also. The second question which everybody will ask is the thing which is not spoken of. I think which Dr. Kapil also was telling, the financial aspects. Correct? So I think it is not wrong to discuss about the rough finances, not the exact thing. I think Dr. Kapil has already spoken about the support which a government also can give. Correct? So to individual person, so Dr. Vimi or Dr. Chetan, what would be the rough cost which you would tell a person when we are counseling for transplant? Because for a pulmonologist to refer a person to another center for lung transplant, it would be unjust if they send a person who cannot afford a transplant. Correct? Yes. So every pulmonologist should know when to refer, what is the likely survival, and what would be the cost of referring a person to the lung transplant unit. Correct? So yes, this may not be exact in numbers, but what would be the rough value which a person should tell, which a pulmonologist should tell?
Sir, on an average, more or less, most of the centers in India, they are doing transplant somewhere around the 30 lakh range, plus or minus, depending on the patient's comorbidities and associated risk, if a patient might require ECMO or not, but roughly it is around 30 lakhs.
Correct.
for a transplant person.
What would
Other
be
thing is
the
that, sir,
yes.
probably in this aspect, there are many, how Dr. Kapil said, even the state government fund, like Chief Minister's Fund, or other options which usually state government supports. And now we can see in this current scenario, there are many crowdfunding that people utilize. So there are many other options, and including some insurance which do support transplant based upon their premium. So along with the general price tag of 30 lakhs, there are other ways which government and other people can support, especially many person know, like whoever is working in a government or non-government organization. There are local supporting groups, like for example NGOs, their colleagues, they usually support in this aspect in many ways. So I think whoever is financially having a difficulty, I think before telling if they cannot arrange at least a 30 lakhs, we should at least promote them or motivate them to use these aspects. And if at all, not at all happening, I think then we have to tell them about the less likelihood.
I think correct.
One
Yeah,
just
Dr. Kapil, quickly, because I think
Yes,
we
sir.
should
Just
end up in another 2 to 3 minutes. We are 16
okay.
minutes behind schedule. Yes.
Sorry. So just last one aspect, sir. I just want to remind that, when we say a number of 30 lakhs, sometimes the unfortunate thing is the patients consider that only the surgery is 30 lakhs. So we have to mention that obviously it's like a 30 lakh package for a 21-day hospitalization, which will include the surgery, the cost of all the intensivists and all the specialties involved. Different centers will have a differential rate of ICU requirement, your medications, your antibiotics, and all of that. So everything is covered in this 25 to 30 lakhs. And I completely agree with what Dr. Vimi also mentioned. We do have a lot of crowd raising options, and these are ideally taken over completely by the transplant coordinators.
Yes, I think, see, this is, I think we should summarize. And before we close, I think we had an excellent discussion. And I'm very sure that we can have another 1 full hour discussing about what will be the ideal time to refer, ideal time to list, and so on and so forth. Personally, what I feel is that all of you who are actively involved in lung transplant should come up with Indian guidelines for referral, which need not necessarily be the ISHLT guidelines, which are more practical. But then I think we should all sit up and work on those criteria so that we'll get more timely referrals, not too early, not too late. I think that is what I personally feel. But before we wind up, I would request Dr. Vimi, Dr. Kapil, Dr. Chetan, one thing which you would ask your referral pulmonologist to remember when you're referring a patient for transplant. One line, that's all. Dr. Vimi.
It is a progressive decline in lung function and persistent symptoms despite medical treatment.
Absolutely correct. Correct. I think that is taken. Dr. Kapil, anything from your side? What
It's
a
very
should always keep in mind.
That there is a big difference between a referral and listing. There is no harm in taking an opinion, at least of a transplant pulmonologist, and the listing can obviously be discussed later.
Absolutely brilliant. Again, this is another important thing. Please do not think that the moment you send a person to the team, they're going to capture and do a transplant. It is not going to happen. They will have an MDD. They will decide when is the correct time, and only then they will do. So referral doesn't mean that it is being listed. Very correct, Chetan.
Sir, early referral can actually benefit the patient, and patient can actually delay lung transplant, because after referral we do a lot of optimization regarding rehabilitation and diet. So there is evidence that just with this rehabilitation, patient will symptomatically improve and goes out of the list, will not be listed anymore.
Very true. So referral may actually delay transplant. Another absolutely brilliant statement. I think all three have given absolutely good statements. From Dr. Vimi's side, keep a watch on the decline in lung function. Keep a watch. I think if it is declining, you should think about lung transplantation. You should offer. The patient may or may not agree. It's a different thing. You have to offer. Another beautiful thing from Kapil, understand the difference between referral and listing. This is again something which we should all remember. Referral, listing are different. And again, third thing from Chetan, it is that when you send a person to a lung transplant team, it will be a holistic thing where other than medicines, the emotional, the nutritional, the rehabilitative components are also addressed. and the person actually may become better. I think we had a beautiful discussion with all the experts, and I think with this, Chetan, can I close?
Yes, sir. Thank you for your valuable time. It was our pleasure having you with us today.
Okay, then I think we will wind up the first webinar of this series on lung transplantation. Thanks to all the audience for logging in, and thanks for our Heart Lung Transplant team for initiating this. Thank you. Bye-bye.
Thank you.
Thank you.
Bye.
Thank you so much. Bye.